Hi my dear friends, today we will discuss infectious corneal ulcers. Corneal ulcers are defects in the corneal epithelium with or without stromal infiltration. Types of corneal ulcers include infectious ulcerative keratitis and non-infectious ulcerative keratitis. By etiology, corneal ulcers are of two types: infectious, which caused by different microorganisms like bacteria and fungi, viruses and protozoa like Acanthamoeba, and non-infectious like local toxic effects of drugs and systemic autoimmune or local or systemic inflammatory diseases. Non-infectious ulcerative keratitis causes local causes like punctate marginal keratitis caused by staph strep infections. Also, punctate marginal keratitis caused by hypersensitivity to medication. Peripheral keratitis associated with blepharitis, also one of the local causes of non-infectious keratitis. Systemic causes as a general manifestation of systemic or immunomediated disease. Most common cause is rheumatoid arthritis, Wagner granulomatosis, and polyarthritis nodosa. The main difference between infectious and non-infectious corneal ulceration is that infectious the patient complains of pain, while in non-infectious usually the patient doesn't complain of pain. There is an infectious discharge, while in non-infectious there is no discharge. In infectious keratitis there is an anterior chamber reaction, while in non-infectious keratitis usually there is absent anterior chamber reaction. In infectious keratitis, the ulceration and infiltration usually central, while in non-infectious keratitis, it is peripheral. History of trauma usually present in cases of infectious ulcer, while in non-infectious, usually the history of trauma is absent. These photos are of peripheral ulcerative keratitis due to autoimmune causes. This photo show peripheral immune ulcer, and here also marginal keratitis, which is considered as peripheral keratitis. Also, this photo show type of ulceration which is near the limbus, and here also ulceration with vascularization near the limbus. All of these photos are caused by peripheral immune ulcers and not caused by infectious cause. Infectious keratitis. Important facts about infectious keratitis. Corneal ulcer we should consider as an ocular emergency, especially with regard to diagnosis and management. When you face corneal ulcer, the time factor is very essential and important. You should know also that despite of varying etiologies and presentation and different treatment approaches, corneal ulcer have one thing in common, that it can cause irreversible loss of vision. So it is considered as an ocular emergency. Principles of management of all infectious corneal ulcerations. 1. The first one is controlling of infection by antibiotics. The second is controlling of inflammation by other drugs, for example, by weak steroids. Promotion of re-epithelialization by lubrication and lid closure and bandage soft contact lenses. And for prevention of perforation by the using of tissue adhesive glue, conjunctival flap, systemic immunosuppressive agents, and corneal grafting. In microbial keratitis, which caused by bacteria, the main predisposing factor are trauma, or in cases of post-herpetic corneal disease, and in cases of bullous keratopathy due to post-phacoemulsification surgery with endothelial damage, and in cases of persistent corneal exposure, as in cases of exposure keratitis, dry eye, diminished corneal sensations in cases of neurotrophic keratitis, and also in contact lens wear. In this photo, we can notice the corneal decompensation with bully, which is called bullous keratopathy. Here is exposure keratitis, which characterized by a corneal ulceration in the inferior part of the cornea. Causative organism in bacterial keratitis, 80% of cases caused by Staph aureus or Streptococcus pneumoniae and Pseudomonas species. Pseudomonas aeruginosa is the most frequent and the most pathogenic ocular pathogen, which can cause corneal perforation in a just of 72 hours. Other microorganisms, bacterial microorganisms that can lead to infectious bacterial keratitis and they can cause corneal infection in an intact epithelium, it include Neisseria gonorrhea, Corynebacterium diphtheria, and Listeria and Haemophilus organisms. All of these four organisms can produce corneal infection in an intact corneal epithelium, so they are very dangerous types of infectious bacterial keratitis. The main clinical picture of staph and strep pneumonia infectious keratitis is that both of them characterized by oval, yellowish white, densely opaque stromal separation surrounded by a relatively clear cornea. Like this photo, we can see an area of yellowish white, opaque stromal separation and infiltration with surrounded by a clear cornea. We can notice here that there is an anterior chamber reaction in the form of hypervin in both photos. Management. Very important here to take a history, especially of history of trauma. Clinical examination which show that there is a corneal infiltration and ulceration with a characteristic features of bacterial keratitis. This patient should be hospitalized as it is considered as an ocular emergency, and we should do corneal scraping by spatula or by a tip of needle. The scraping material should be stained by gram stain to show that it is gram positive or negative, or by staining by other stains for fungal infections, and then we can do a culture for it to know the causative organism. Differentiators of bacterial keratitis. It causes usually acute painful injected eye, previous tearing and discharge, marked decrease in the visual acuity. Usually we can find a foreign body in the cornea which causes this infection, and usually there is stromal invasion with epithelial ulcer with excavating edges. Treatment here, very important, and to know that our treatment we should start rapidly without waiting for the result of culture. The result of culture can modulate or modify our treatment, but the main treatment line here will be the use of a broad spectrum antibiotic which can cover gram positive and negative like fluoroquinolones. First we give it every 5 minutes for hours, then every hour for first 24 hours, then every 2 hours for every 24 hours, and then 5 times per day. In the second line we can use, instead of broad spectrum antibiotic, we can use fortified eye drops. One cover gram positive and another one cover gram negative. Mainly we use vancomycin for gram positive, and we use ceftazidime as a cover for gram negative. Both eye drops should be used frequently to control infection. The third option here is the use of steroid. Can we use steroid in these active ulcers? The use of steroid here is questionable, and steroid can increase the liability for progression of infection, but we can use it as with undercover of antibiotic in very minimal doses to decrease the action and injection. Fungal keratitis. It is caused mainly by two organisms. Filamentous fungal keratitis caused by Aspergillus or Fusarium, while the second causative form of fungal keratitis is yeast candida. Clinically, usually fungal keratitis caused by a vegetable matter injury. This vegetable matter injury will cause an implantation of the fungus to the corneal wound. This will lead to fungal keratitis, which characterized by grayish-white ulcer with indistinct margins surrounded by feathery infiltrate like this. Usually, these infiltrates surrounded by an area of ring infiltrate like here called ring abscess, endothelial plaque, and hypobion reaction in the anterior chamber. Differentiators of fungal keratitis. Usually it is characterized by dull gray infiltrates, satellite lesions. We should be aware that these ulcers can be mistaken for bacterial keratitis, and we should know that ulcers caused by yeast usually has a well-defined borders. Candida keratitis usually develops in pre-existing corneal disease or in immunocompromised patient. Usually it is a yellowish-white ulcer with dense separation. While inflammatory keratitis usually characterized by firm elevated necrotic staph or what's called hyphae lines that extend beyond the edge of the ulcer to the normal cornea, causing what is called feathery or satellite infiltrates in the corneal stroma, like in this photo. We can see that there is a primary lesion and here is a satellite lesion away from the primary lesion. Management of fungal ulcer by culturing at specific media called spheroid media. Biopsy of the corneal tissue if we can diagnose it well by culturing, and we should start rapidly antifungal therapy. Initially, we use a broad spectrum antifungal like iconazole, voriconazole topically, hourly, then 5 times per day. Then, according to sensitivity, we can add natamycin or imidazole for 6 weeks. We can use also systemic antifungals like systemic ketoconazole in cases of immunocompromised patient and if the corneal ulceration near the limbus. In severe cases not responding to treatment, we can do therapeutic penetrating keratoplasty. Acanthamoeba keratitis, one of the protozoa which causes infectious keratitis. Its active form called tropiszoid and dormant form called cystic. Common in cases of swimmers and contact lens wearers. Clinically, it characterized by blurred vision and disproportionate pain to the clinical picture which present. Usually patient of Acanthamoeba keratitis suffering from severe pain. Also, it is clinically characterized by patchy anterior stromal infiltrates with perineural spread, which called radial keratoneuritis. These infiltrates coalesce together and forming what is called ring abscess ulceration and hypobion, with wide satellite lesions. Here is the picture of Acanthamoeba keratitis. We can notice the ring abscess formation, and this ring abscess will followed by necrosis and melting. Management: corneal scraping stained here with cauliflower white to diagnose Acanthamoeba. We can do also corneal biopsy. Treatment of these cases done by anti-Acanthamoeba drugs like chlorhexidine and polyhexamethylene biguanoids drops, and also by dibromamidine and bromamidine eye drops. Also, therapeutic penetrating keratoplasty is still an option. Viral keratitis. The first of viral keratitis causes organism is herpes simplex virus. It is an epitheliotropic virus and may become a neurotropic. It includes 2 types, herpes simplex virus 1 and 2. Herpes simplex virus 1 infection occurs most commonly in the mucocutaneous distribution of the trigeminal nerve. Classification of viral keratitis caused by herpes simplex include epithelial stage, which is called epithelial keratitis like this photo, forming what is called dendritic ulcer, And the second stage is disciform keratitis or stromal keratitis, and here there is an immune reaction against the virus, which lead to some sort of endothelitis and corneal edema like here and here. If this ulcer is very large and severe, it forms what is called metaherpetic ulcer or ulcer metaherpetica. In severe cases with severe immune reaction against the virus, necrosis of the corneal tissue can occur and leading to what is called necrotizing keratitis. Also, the viral ulcer can be associated with uveitic action or inflammation of the uveal tract, and here it is called keratouveitis, in which we can see that there is a corneal affection with anterior segment or anterior uveitis with keratic precipitates and anterior chamber reaction. Differentiators of herpes simplex keratitis. Usually, it is diagnosed by the dendritic ulcer appearance, which can be diagnosed by fluorescein dye or by rose bengal stain. The second is loss of corneal sensation and usually photophobia, and blepharospasm is absent in herpes simplex keratitis due to loss of corneal sensation. Types of herpes simplex keratitis infection can be primary, recurrent, dendritic, geographic, and can lead to neurotrophic keratitis, which was called diabetic foot in the eye. There is loss of corneal sensation, which lead to neurotrophic keratitis. Treatment of epithelial keratitis by topical antiviral like acyclovir, ophthalmic eye ointment, and trifluoride eye drops. Herpetic stromal keratitis is treated initially with steroid-like prednisolone drops every 2 hours combined by prophylactic or under cover of antiviral drugs. In cases of metaherpetic ulcers, treated by artificial tears, lubricant, and stopping toxic medication, and performing punctal occlusion to allow lubrication of the eye with tears, and also bandaging the cornea by bandage contact lens, and last amniotic membrane grafting to cover the area of ulceration and allow its healing. Herpes zoster keratitis. It is caused mainly by varicella zoster virus. It causes in young age or in children what's called chickenpox, while in old age called herpes zoster infection or what is called shingles. Risk factor for developing of herpes zoster keratitis in cases of increased age, more than 70 years old, neoplastic diseases, immunosuppressive drugs, organ transplantation recipients, and human immunodeficiency virus. All these conditions will lead to decreased immunity and appearance or recurrence of the herpes zoster infection. Herpes zoster ophthalmicus, characterized by unilateral painful skin rash in one or more dermatome distributions of the fifth cranial nerves, trigeminal nerve, like this photo. We can see that rash follows the distribution of the fifth cranial nerve, one or more dermatome. Hutchinson sign, it is appearance of vesicles at the tip of the nose of the affected patients, which are a potential indicators of an ocular disease. First presentation after this skin rash, usually corneal and anterior segment affection, which include acute epithelial keratitis in form of dendrites, but here these stained dendrites characterized by tapered ends without terminal bulb, not like the dendrites of herpes simplex keratitis. The second form is nummular keratitis, which are fine granular subepithelial deposits, like in this photo. The third form is episcleritis. Fourth form is scleritis and sclerokeratitis. And fifth form is herpetic stromal or interstitial keratitis, like this photo. And lastly, anterior uveitis can occur due to involvement of the anterior uveal tract. Other manifestations which can present are posterior uveitis, neurotrophic keratitis, and scleritis. This photo of a neurotrophic keratitis due to permanent loss of corneal sensation. And here this photo shows a case of anterior scleritis with area of previous attack, we can notice that the gray area of atrophic changes in the sclera. Also, skin is affected by eyelid scarring, leading to occurrence of cicatricial entropium. After the attack of herpes zoster ophthalmicus, the patient can suffer from post-herpetic neuralgia, which is a very severe pain which can follow the attack of herpes zoster ophthalmicus, and other neurological complications like third nerve palsy or other cranial nerve pulses. Treatment. Main treatment here by oral antiviral drugs like oral acyclovir 800 mg per day 5 times daily for 7 to 10 days is the standard treatment. The second is topical antiviral treatment in cases of ocular corneal involvement. We can use topical steroids with undercover of antiviral drugs in cases of uveitis. Pain should be controlled by the use of narcotics and topical skin ointments for skin lesions. Thank you very much, and I hope you enjoy my presentation. Thank you.